therapeutic for very limited, okay, and for treatment. Okay. For diagnosis, after any trauma, suppose patient develop, it's relaxing, okay, patient develop effusion, okay, after a few days it may become warm. No, we don't know whether it is only the simple the hemarthrosis or could be the septic arthritis. Okay. So we need to confirm the diagnosis. Simply patient present with without any trauma, knee effusion. Old people like osteoarthritis can develop reactive arthritis and synovial reaction and effusion. In rheumatoid arthritis, yes, it could possible. Some joint arthropathy also can lead to the effusion, and then we have to confirm the diagnosis. And the most important is the septic knee. For septic knee and all this, one method is to go for non-invasive technique like MRI, okay, which can give us either it is a blood or is fluid or pus. But MRI is time consuming. We cannot do MRI immediately. And if it is, especially if it is septic knee, it is really an orthopedic emergency. Any joint infection is really an emergency, like open fracture. We cannot wait. Every minute is very crucial. So we want to diagnose as early as possible. So that's why easiest method, insert a needle, tap the fluid, inspect it, send for the microbiology lab or gram stain. If it is infection, proceed for the procedure. Because if it's septic knee, we have to go for the joint wash, lavage, arthrotomy. Okay. Okay. Now for our indication, confirm the diagnosis. If there is septic knee, aspirate and send for all the labs. Some joint arthropathies like crystals or uric acid gouts, to send this to confirm the diagnosis. Okay, they will in the lab they will see under the light and they will find the crystals. For therapeutic, we are very limited now use, because in joint effusion, if we will aspirate, what will happen? The same fluid will reaccumulate. So very little indication for therapeutic aspiration. And the third indication is the injections. Okay. In orthopedic practice, for osteoarthritis, now we have two options. In the early osteoarthritic phase, we are giving injection hyaluronic acid, this chondroitin sulfate. Still, it is theoretical, not yet proven, that this chondroitin sulfate stimulates the cartilage cells growth. Still in an early phase. So for patient satisfaction or for trial basis, we are giving injections, or in the latest stage, we are giving these steroid injections, or to relieve the pain and subside the swelling edema. So these are the indications for any tap in the knee, needle in the knee. For approach, whenever we release the patient, always explain. First, always this is an international standard protocol. Whenever you are reaching the patient, just introduce who are you, okay, and what you want to do. You know that patient has knee swelling, so you will inform the patient that you have effusion and I am suspecting septic knee or whatever. And to confirm the diagnosis, I am going to aspiration. Okay. So to take the consent from the patient. In our hospital, KKUH, just verbal consent is enough. Okay. No need to take the written consent, like in the military and National Guard, they have the trend. For even any aspiration, for any procedure, they are taking the written consent from the patient. But KQH, no. Just you have to discuss with the patient, verbal information. If he is agree, we will proceed for our aspiration. The prerequisite for the aspiration, you are introducing your needle in the joint. So it should be very clean aseptic procedure. If we will not take precaution, we can introduce the infection inside the joint. Okay. So exposure of the limb should be from the mid thigh to the mid leg, and all the things required should be all destroyed. One thing should take care that if there is an infection around the knee joint, like cellulitis or any boil, then in that situation we should avoid that area for aspiration. Okay. Site of aspiration, any idea? Suprapatellar and infrapatellar. Suprapatellar usually for aspiration, okay, and infrapatellar usually for procedures like arthroscope or injecting any injections, give injections. So where are the sites now? For suprapatellar, this is patella, front of the knee. Okay, this is patella. 1 centimeter above, draw a line. Okay, imaginary line, and this is medial aspect. This is lateral aspect. 1 centimeter lateral to the lateral border of the patella. Draw another imaginary line. Okay, so 2 lines. The point where the 2 lines are meeting is our
Injection
aspiration. Aspiration. Okay. From here we are actually aspirating what? Suprapatellar. It is not the knee joint directly. It is the suprapatellar. And in 90 to 95% of the patient, suprapatellar power is communicating with the joint. Right? So this is our side, and we will introduce our needle about 40 to 45 degree from the ground. Okay, so 40-45 degree from the ground at the same level. One is our, and it should be usually lateral side. Okay. If there is an infection in this area, suppose cellulitis, in that situation we will go medial. Same, 1 centimeter above and 1 centimeter medial. If you have medial, medial to the border. The same 2 lines, imagine the where the 2 lines are meeting, same point. Okay, this is our.
The needle goes.
No, not straight.
No.
Like 40 to 45 degrees
45 degrees.
from the ground.
Okay.
From the floor.
So what about the position of the lips or extension?
No, extension. Okay, same as it is. Okay. For suprapatellar, same as it is. Okay. The other point is or site is the infrapatellar area. For infrapatellar, the knee should be in flexion. It should be 90 degree inflection. Right? This is our patella. Okay. This is tibial tuberosity. And what is attached here? From the lower part of patella. Patella. Okay. On the both sides, medial and lateral, there are soft area above the tibia. This is the point from where we are aspirating or for how to assess? Just palpate the tendon, okay, and go either medial or lateral. Or other, feel this shin, tibia surface, go. The first soft point above the bone, bony. The first point above it is our site of injection, aspiration, needle insertion. Okay. Either medial or lateral, wherever your preference, both. And direction should be towards the notch. This is femur. Between the, we have femoral condyles, medial and lateral, and between the condyle there is usually a space, the notch. Okay, and we are directing in that notch. Okay, it will go straight or like more, you will hit the bone. Okay, should be in the middle, about 30 degree towards the notch, middle of the notch. Right? Any question till now? Anything till now? Okay.
Good.
Now for aspiration, you should have an assistant with you. Okay. The surgeon should have an assistant, the one who is aspirating. Yes. Gloves are available.
Okay.
No,
Sterile?
sterile. No.
This is sterile.
No, these are not sterile. We need the sterile. Check that one box. The one.
I'll
Box. Yeah. What is the size? 10.5?
6.5. 7.5.
Acceptable. Okay. So we need sterile glove, sterile dressing bag, okay. Some fluid, alcohol or povidone or chlorhexidine, anything for clean the area. Okay. They did not provide us the drip. Okay. After the cleaning, we have to apply the drips to cover the area, because we will clean this area. This area is still unsterile. Okay. We need some needles. I will tell you the sizes. Syringes, gauze pieces. Okay. Sterile gauze pieces and needles. For the juniors, we have to give the local anesthesia in this area, because senior, he know the site, he will go only once, usually once or maximum 2 times, and he will directly, the senior will directly approach or reach the desired area, the super aspirate, and they can aspirate in single tap. But juniors, maybe he will not reach there, maybe go once again, 2, 3, 4, 3 or 4 pricks, so painful for the patient. So in that situation, better to give the local anesthesia at the site of your aspiration or injection, right? For local anesthesia, we are using 1% xylocaine, lidocaine. Okay, this is 1% xylocaine. It's already finished. We will use water instead of it. Okay. If it is new, just remove this cover and aspirate. Take the xylocaine. Okay. If it is not, the assistant should clean it with alcohol. For local anesthesia, 3 cc, 4 or 5 cc syringe is enough. Right? And needle, usually we are taking smaller needle. This is 22 gauge. Acceptable, better to take 23 or 25 gauge, small needle. Okay. After the xylocaine, just wait for 1 or 2 minutes, let this xylocaine or local anesthesia to affect, then proceed for the aspiration. For aspiration, again, we need the new needle and syringes. What size preferably you want? What should be for aspiration?
Super. Size.
Size.
25.
No. 25 will be very small. If you will go back, it will increase in size.
18, 16.
18. 18 or preferably 16. At least 18.
Inspiration.
Because the fluid inside, if it is very thick, like pus, you cannot aspirate with a small needle. It will block. Right? So 18 or preferably 16, the needle. For average people, the long needle this much is enough. The length of the needle. You can reach there. 2 centimeter, 2.5 centimeter, this is much enough. But obese people, thick people, you need a longer needle. Otherwise, with this, you cannot reach the suprapubic pouch. So in that situation, we have to use the spine needle, which are longer. Okay. Again, should be same 18 or 16 gauge spine needles. And the size of the syringe, at least 10 cc. Okay, because once you aspirate, you have to collect the sample for your gram stain, culture of this thing. Okay, 10 or maybe 20 or 30 cc, bigger syringes. They did not provide, but you should know this thing. Okay. After you collect the sample, you will send for gram stain, culture, cell count, and for crystal analysis. Okay. Sometimes for chemistry. And if you are suspecting tuberculosis or fungal infection, we have to send for that, AFB and fungal also. So different containers, the assistant or nurse with you, they usually know, they all are color coded. Okay, so they will guide you how to send which bottle for which test. And after aspiration, we should apply the cotton